Hi, everybody. I hope you are well, and I'm going to assume that most of you are all in Sydney, and I hope you're doing lockdown okay. I know it's very challenging for everybody. Thanks for joining. What we're going to be talking about today is robotic gait trainers and how they can improve walking after stroke. This is in honour of Stroke Week, which we're really excited to be hosting a series of lectures on. If you've got any questions, please do pop them in the chat box, and I will be coming to all of those questions at the end of this presentation. So whenever you think of a question, just go ahead and pop it in the chat box. So the device that I'm going to be talking about specifically is called the Lexo. And this is a Tyromotion device, and it's actually an end effector device. There are two different types of robotic gait trainers out there. One which is quite well known and has been in the market for well over 20 years, which is called the Lokomat. That is an exoskeleton device, and I'm talking about one of the newer types of models of robotic gait trainers called the Lexo, which is an end effector device. And I'm going to go on and tell you a little bit more about that and how that improves your walking. All right, so let's get started if I can get my slide to go. So the reason we started to explore robotic gait training devices was because of some of the major issues that we experienced in gait training. And we do a lot of stroke rehab. We do a lot of gait training post-stroke. So we feel that we're fairly across this area. One of the biggest issues that we experience is low step rate. So on average, and we know this from the literature, but also our own investigation with clients, is that on average, patients are walking about 550 steps in a session. And we know from the literature that changes really only start to become quite significant when you're averaging around 2,500 steps in a gait training session. So it's not to mean that you won't improve at the lower levels, but it's just not going to be as significant. So we wanted to look at how we could increase the number of steps per training session. We find that typically the sessions are quite low intensity, and we mean that in terms of increasing your heart rate. And there's very little time actually spent in a heart rate training zone that's going to improve your fitness and going to improve your endurance. And we do that with a heart rate monitor during the session to kind of evaluate how much time you're spending in that heart rate zone. And we know from our own investigations and also from the literature that is typically very low, if not 0 to 5 minutes of time spent in that heart rate zone that's going to get you fitter and with more endurance. We don't typically experience this problem with our client base, but there can also be motivational issues. So decreased compliance, people not wanting to commit to the volume of training that's required to improve walking after stroke. So there's an adherence issue that can become quite a big problem. It's very labour intensive to assist in some instances post-stroke. And this could look like having 2 or 3 therapists assisting you walking, even when on a treadmill. If you need assistance getting your foot through whilst you're on a treadmill, somebody to make sure that you're upright and safe. And so what this can do is obviously it increases the resource demand, but it also limits what the therapist can do to refine your activity and to really guide the movement, because they're very conscious and doing their job of holding you upright or moving your body weight over. So it's very labour intensive to do it otherwise, with or without a body weight support harness. And what that means is either on a treadmill or on overground training, that can actually be reinforcing inefficient and effortful walking patterns. And so we don't want to be creating and reinforcing compensatory movement strategies to get you from point A to point B. And this was one of the really important things that we wanted to kind of address in our next step. There can be biomechanical joint stresses and pain if there's any predisposing osteoarthritic changes in the joints, if there's changes because patients are more sedentary, lots of different things that can also limit the amount of time that you might spend upright and walking. So that was one of the things that we wanted to look at as well. And then obviously safety concerns. If you're very dependent for walking, you need a lot of support to hold you up, but there is a risk that you could fall, which would either hurt yourself or the person assisting you. This can have an impact on confidence. It can have an impact on adherence, motivation, and all those factors, which all weigh in. And so these were some of the main issues that we sought to address. And I think what led to improving walking outcomes. Just to touch on some of the evidence really briefly, I mentioned before around 2,500 steps is kind of the baseline threshold for what's going to give you significant improvements in your gait post-stroke. And one of the pioneering articles was Hornby and colleagues, and they actually looked at forcing step dosage on a treadmill. So this was without a bodyweight support harness, but you could equally do it with for additional safety. And they started to achieve anywhere from 2,500 to 4,000 steps in a training session versus the normal gait training sessions, which were around 550 to 1,000 steps. And what they saw was this translated into a very significant real world change. And that's ultimately what we want to do. It's not just about getting the number of steps up on a treadmill or a robotic training device. It's about what that means for you in your everyday life, and about getting you fitter, stronger, about getting your step length more symmetrical, getting your weight shift happening, avoiding compensatory and inefficient movement patterns, etc. And this was one of the articles that really started to define that there is a threshold, and we need to be aiming to achieve at least 2,500 to 4,000 steps if we want to achieve real world walking goals and improvement outside of the clinical setting. And one of the other things that we looked at was, again, the same group of colleagues looking into stroke, but looking at intensity. And what they looked at here, just in this graph here, is in the red, they had a group that were walking on a treadmill, but at a high intensity for their heart rate. So they were making them work quite hard on an incline. And then they had another group in purple, and they were walking over obstacles, but again, they were working them on inclines and ramps and all sorts of things that were really getting their heart rate up as well. And so two of those groups were focusing on keeping their heart rate up nice and high. And then the third group in the blue, the low variable, they were walking on obstacle course, etc., but they were keeping their heart rate low. And so you can see here the two groups that had high intensity, so they got their heart rate up nice and high and sustained that throughout the training session. They did remarkably better, both in self-selected walking velocity, so the speed of their walking, and also the distance in their 6-minute walk test, which is something that we routinely do to measure your distance of walking. They did substantially better than the group that had low intensity training, even though the training itself was the same. So we know that intensity, the amount of your heart rate gets up through the training session, is really important as well. And that can be really hard to do safely in a clinical setting if we're too busy trying to hold you up. Or it might look like we get you on a bike, for instance, which will increase your fitness, but doesn't always translate to what you're doing in a weight-bearing and walking scenario. So here are just some quick snapshots. You can see here the number of steps. This was an audit that we did across our client base just to see where we were before we started using the robotic gait training device. And you can see here that this gentleman was walking 633 steps in a training session, only achieving about a minute in his heart rate training zone, 140 steps, no time spent in heart rate training zone, 710 steps, just over 10 minutes. And this gentleman here, who was doing really well in his training session, he was actually achieving over 2,000 steps in his training session, and quite nice, 12 minutes. And we know for fitness training that really the threshold is about 12 minutes or above of time spent in that cardiovascular training zone. So that's about the minimum that we want as well. Just try and get on. So how do we improve walking outcomes? We knew what the limitations were. We knew what we were doing, and we were very well versed in body weight support treadmill training. So this is having a harness over a treadmill and trying to achieve increased stepping dosage and intensity. But as I said, the limitations of this are resource, which means you might have 2 or 3 therapists, which becomes then self-limiting for cost and time allocation. And we could be constantly reinforcing inefficient and effortful gait patterns. So we knew that it was good, and we continue to use body weight support treadmill training strategies, but it's not as good as it could be for those reasons. And so we started looking at robotics. And as I mentioned before, there are 2 different types or designs of robotic devices. One is an exoskeleton, which can either be a fixed device, a standing robot, or it could be something that assists you to walk over ground. And then there's the LEXO, which is an end effector device. So unlike an exoskeleton, which is articulated at the hip, the knee, and the ankle, and it forces a very strategic moving pattern, the LEXO is an end effector where your feet are strapped into a foot plate, and it's the foot plate that moves you, but you've got freedom to move between the knee and the hip. And that's what we think actually enhances the amount of learning that people do within the device. And that's why we're getting better outcomes from an end effector device. So again, just to touch on some of the literature, a Cochrane review, which is probably the highest level of evidence you can get, looked at body weight support treadmill training and exoskeleton devices. And the Cochrane review was able to pull together about 1,472 patients, which is often what the Cochrane review will do, and showed that both of those devices did not improve the chance of gait independence compared with conventional physical therapy. So that was quite profound, I think, in the Cochrane review to show that. However, they did show that the use of a robotic end effector gait trainer like the Lexo did increase the chance of gait independence, which is obviously very significant if you can't walk independently. So that was the first thing that piqued up our interest. And then the third thing was that people in the first 3 months after stroke and those who are not able to walk benefit the most. So what they're talking about here is that if you are in the acute stage or the subacute post stroke phase, that's when you're going to get the most benefit of using a robotic gait trainer with an end effector device. And I think part of the reasoning around that, it doesn't mean that you won't make significant gains down the track. It's just that those compensations start to kick in, and you might also start to experience changes in soft tissue length, strength changes, fitness levels, all those sorts of things make it much harder down the track just to reverse those changes. But it doesn't mean that you certainly can't make changes. It's just what they didn't find that in the research at the time. And then Mersholz and colleagues went on to find also that the end effector gait trainer improved gait velocity and maximum walking distance. So that's obviously self-selected speed and your ability to walk fast under duress, and also maximum walking distance, which is really important if you want to walk around the shopping centre or walk to a cafe to get a coffee or whatever it might be. Overall endurance is very important for quality of life. So I wanted to show you what the Lexo was, because this is the device that we invested in. I flew over to Austria in September 2019 to have a look at the first prototype, and we purchased the very first device that they ever made. And so far to date, it's been absolutely outstanding. It's done exactly what it said it would. And so you can see here, if I can get my cursor down on the feet are strapped in. So you've got freedom to move between the knee and the hip. You have a harness that's supporting you from the top. And what this device does is it forces a physiological and very efficient gait pattern. And it will do that for you. It'll do that passively. And then the therapist will focus on a particular component of your walking to improve that. And it may well be the way that you land on your heel. It may be the amount of weight that you distribute from one side to another, which can be often very challenged post-stroke. It might be how much toe clearance you have through that swing phase. It can be any number of things. And the beauty of this device are the sensors that fit within the foot plate, which mean you get very instant real-world data on what's happening and how you're moving. And that means the therapist, because you're strapped in and you're safe, can take a step back and actually look at what's happening and how your movement can be further refined, further improved. We can certainly look at getting your step numbers up nice and high over the 2,500, sometimes 3,500 steps. And then look at increasing your speed of stepping as well, which is your cadence. And we often find in stroke that this is very much impacted because people don't tend to be able to shift their weight comfortably over to the more affected side. So they're not standing on that side long enough in order to get that other leg through. So it becomes a very hobbly, shuffly gait and very lopsided. And so this will force that weight distribution. And then the therapist can further encourage or overtrain to the more affected side. So you're building up strength and you're retraining a more effective way, a more efficient way of walking. So some of the benefits that we found with the Lexo are certainly the dose of stepping that you get in a training session. And what we found, because we've had the device for over 6 months now, we kind of underestimated how fit you would need to be to get to that dose. And so what we found is we started people on 30 minutes, and most people can only tolerate about 30 minutes of stepping before you're absolutely shattered and you need to hop off. But over time, you can build that up to 45 minutes and get more up to that 2,500, 3,000 stepping number. So dose is really important, but it might take you a little bit of time to get up there. Intensity, we've had heart rate monitors on people monitoring their heart rate, and this is fantastic. It gets you working really hard. Even though the device has a passive mode where it will do the stepping for you, it's your ability to override components of that, or if you're good enough, move into the active assist component where you're driving the machine. You can get your heart rate up beautifully and sustain that for most of the time. I talked about precision. Because of the sensors within the foot plates, you get beautiful real-time feedback. So the therapist can really refine and make your walking pattern very effective and efficient. And we see that carried over into overground walking Some people, they'll have 24 hours of carryover where their walking feels much better, and we've videoed this, and it looks beautiful in terms of symmetry, stride length, evenness from left and right. Some people even sustain this up to 72 hours. So we don't have any published literature on this at the moment, but our anecdotal analysis of this is very promising in that carryover domain. It's really rewiring and retraining that movement efficiency. It's highly motivating for people. They really enjoy the experience of being upright and walking. Some people have said, you know, it's the first time they've felt like they've walked normally since their stroke. And I think that's really powerful, because a treadmill's not going to do it for you. An exoskeleton's not going to get you up to the right speed. It's not going to give you the sufficient dosage that's required. This is the first device that we've come across that is going to give you a normal and efficient walking pattern. You just then have to do the steps, the dosage, and learn how to rewire your brain for the most efficient walking pattern. And then obviously it's decreasing risk of injury for you as a patient, because you know, you're not dependent on another person holding you up. If there's a misstep or anything, that's just not going to happen on the device. It's reducing the amount of resource from a clinical perspective as well. Not only that, the therapist can actually take a step back and look what's happening. And the therapist is much less likely to injure themselves as well, which obviously means that they're able to do a lot more within the session, and they're not limited by their own physical capacity to either hold you up and get you walking longer. So from all of those perspectives, it's an absolutely incredible device. Some of the considerations, what we've found certainly is it's incredibly accommodating. So we've had a lot of patients on with fixed ankle foot orthoses. So if you do wear an AFO, that's not a limitation. You can still hop on the device. Even if you've got a minimal contracture of the knee or the hip, it can be accommodated up to a point. So about 10 degrees at the knee and about 5 degrees, 10 degrees up at the hip. And that's incredibly important, because it means that the device can be used across a very broad spectrum of people. And certainly down the track, if you've had a stroke 5 or 10 years ago, you might experience some of these limitations of range of movement already, but it means that the device can accommodate for that in most instances. Spasticity, we've had any number of significant spasticity in our patients, and certainly in some of our spinal cord injury patients, we've had a lot of clonus as well, which is when you get this perseveration and tremor within the leg. It's very powerful, but the machine will work with you. It tends to override that. And then if we can increase your speed, and we typically see it around 80 steps per minute, that clonus tends to reside a little bit, and we get these central pattern generators kicking in, and the stepping pattern is beautiful. So spasticity can be well accommodated as well. Trunk control, because of the body weight support harnessing device, tends to be very well maintained, and the device will move laterally as well as up and down, and it's got a dynamic capacity for that, so that you are not hampered or limited by that body weight support either. Some of the considerations are just being able to follow commands and to be able to communicate if you're uncomfortable or you need to stop. They're some of the things that we would assess for and screen for in the assessment. What your goals are. And what we found is that there are two different types of people that we will get on the device. One is somebody who has walking goals, wants to improve their distance, their speed, their endurance, their independence perhaps. And we call those functional walking goals. And that's opposed to somebody who might be much, much further down the track, and they just want the experience of being upright and feeling what it's like to walk again. And so they may not have functional walking goals, but they want the experience of being upright. And that in itself has enormous benefits, both psychologically, but also from a bodily discomfort domain, also in constipation, just getting everything upright, blood volume training as well, so that you don't pass out if you're sitting upright for too long. Lots of different areas that this has really important goals for as well, even if it's not a walking goal. And then we obviously just need to screen for any other comorbidities, which might include difficulties with sensation, particularly because it's got a harness that's supporting your weight, or a saddle that you might be sitting on. Any cardiac issues that might be of concern, or if you've got any unstable cardiac conditions. Your overall fitness will impact the amount of time and dosage that you can spend on the machine. And those are sorts of things that we will all do in the assessment. And so just to finish up, we use the LEXO as part of our Stand, Walk, Run program. So as I mentioned before, it's not just about getting you on a machine and getting your steps up and assuming that that's all going to be fine. We then need to translate that into what you're doing off the device, what you're doing at home, and how you're getting the biggest bang for your buck. And this is what we think the Stand, Walk, Run program really does for people. So it's about doing the stepping, the dosage, getting your heart rate up on the machine, having a little break, and then putting that into other scenarios around obstacles, multi-directional stepping, which you can't do on the machine, stepping up and over obstacles. So more like what you would do when you were out and about or getting around inside the home or the shopping centre or whatever it might be. So it's really about translating that walking into then more functional contexts. And so this is just a case study I wanted to show you here of Michael. So this is when we first assessed Michael, and he's walking pretty well. So doing 710 steps, and he can get his heart rate up during the session. But you can see here there's some asymmetry in his walking. His leg turns out a wee bit, and he wants to work on the quality of his walking and also his ability to walk further and with more confidence. And so even in his very first session on the machine, we were able to achieve that lovely weight symmetry, and the gait step variation was reduced. Well, there was no gait variation because he's stepping the same distance on both sides. He's taking just about all of his weight. So the body weight support is on there for safety, but he's actually not requiring it. And then his therapist can take a step back and look at what he really needs to work on. And in this case, it might be heel strike on the left foot. So getting his foot to strike, and the machine will give you a lovely smiley face or percentage of how much your weight is going down on that left heel, if that's what he's working on, or it might be foot clearance. And so as he's getting used to the machine, over time, what his therapist, Sarah, will do is start to increase his stride length to more what he would need for his respective height, increase the speed, and then that will increase his heart rate, and then his fitness may be a limiting factor. So this is how we would slowly transition somebody. And now Michael's doing, up to 45 minutes on the device and doing a lovely job there. And this is another case study. So this is Catherine, who's been with us for some time now. And you can see on the treadmill what I was talking about before. She's safe. She's not going to go anywhere. But we're just still reinforcing a very compensatory movement strategy with quite a lot of asymmetry in weight distribution from left to right. And the step length is quite different. And so what that means is that endurance, fitness is impacted, her ability to walk long distances, to walk independently, all of that. Although we're getting some beautiful training in there, we can do so much more on a device like the Lexo, where we are forcing the step length to be even. We're shifting the weight to be even left and right. And she's getting a lot of task practice in doing that. So this is Catherine's first or second time on the device, I think. And you can see here, Catherine's just hanging in the straps, getting used to it. She's got her AFO on, so very accommodating in that respect. Now she's starting to take some weight. And the biomechanics are lovely here because we're starting to see some beautiful extension through the hip, which we wouldn't normally see. So that's giving her a really big stretch. And again, just starting slowly while she's getting used to the device. It can be a little strange when you first get on a device and it's walking for you. And then as confidence builds, then we can start building up the speed and the distance and time spent on the device. So in summary, basically, we've been able to show that we can get people up to the 3,000 step average over time. It's more of a fitness limitation for most people, but we can certainly do that. And that's happening across the board once we have that as a key focus, and that's compared to about 500. So we're starting to see that translate into real world change. So yes, we've been able to tick that off. Certainly we've seen a huge increase in the amount of time spent in the heart rate zone. So the device has been able to tick that off as well. Typically it's a single therapist setup, which means we don't need 3 people to hold the harness in place, somebody to move weight over from left and right, and then somebody on both feet perhaps. So in terms of resource investment from a clinician's perspective, it's usually only one person. Sometimes we might need an allied health assistant to help us set up if there's a lot of limitation in movement. And it's very quick, and we can average anywhere from 2 to 9 minutes to set somebody up. So it's not eating into your therapy time, which is very, very important. I think devices like the Locomat can take up to 25 minutes. So you're spending up to half an hour getting on and off the device, and then only half an hour actually achieving any stepping. As you can see, there's a programmable gait pattern. So we can adjust the speed that you're walking, the step length, the amount of distribution, weight, left and right, all of these things, which mean that we can really refine how you're walking, put that into practice, do lots of stepping, repetitive task practice, and then get you off the device and get you to practice that yourself as well. So we're not working on compensatory strategies. We're not reinforcing inefficient movement strategies. And I think that's really important and one of the best features of the device. Obviously, we can take some of the weight off as well. So if there's problems in the knees or the hips, especially while you're walking at that higher level and you're building up your strength as well, we can vary the amount of body weight support. So that can limit and reduce a lot of the pain and discomfort that a lot of people might experience. And we typically, after the first initial orientation of the device, we haven't had any safety concerns. Patient confidence is very high. Therapist confidence is really high, and it enables the therapist to step back and really evaluate and refine the walking pattern. And I think that's really, really significant. And again, something that we probably hadn't factored in as much when we were first looking at purchasing the device. So hopefully that's given you a really good idea of what robotic gait trainers can do, in particular an end effector device, which is where your feet are strapped into the foot plates. I would hope to see a lot more of these devices around Australia as they become more common. They are quite a significant financial investment. People often ask me around the price, but I think everything we've been able to demonstrate in the clinic, and the patients absolutely love it, is it's been a very, very well worth or worthwhile investment, I should say. It's been fantastic, and the outcomes have been quite significant when we compare to our normal walking patterns. So yeah, I'd love to take any questions now if you have them. So I'm just going to open up the chat box and take any questions if you have any. And if you don't, or you haven't thought of any at the moment, but something comes to mind later, please don't hesitate to email me at this address here, melissa@archealth.com.au, and I'd be very happy to answer any of your questions. So I'll just give you 1 or 2 more minutes. I can see a few of you on there. So 1 or 2 more minutes to pop a question in. Otherwise, thank you very much for joining me. No, I can't see any questions there now. All right, well, we might wrap up there, but, oh, okay, no worries. Thank you. Thanks, everybody. Yes, okay, email me. Yeah, so particularly if you've got personal questions, I'm very happy to try and answer them. How can you transfer people onto the device is one question. 2 different ways. You can either, if I can go back to this graphic here. So this device up here actually will be a hoist. So if somebody's wheelchair dependent, the device can come out and then we can strap you up to the harness, and it will lift you up, transfer you onto the device. Otherwise, if you are already ambulant and walking, you can just step onto the device. These little arm rests here will swing out of the way and you can step onto the device. So 2 different ways. You can either Superman it on, or you can simply step onto the device. Lovely. Sounds like it's less suitable for people several years post spinal cord injury. Not necessarily. We've had a lot of chronic spinal cord injury patients on the device. Again, it will depend on bone density, is probably one of the biggest limitations. So we will need to screen for bone density, because we obviously don't want to cause any fractures, for instance, and also your capacity to stay upright. The device will create a bit of a muscle pump, so it's unlikely that you will experience a vasovagal, but if you have not been standing up for long periods of time, this would be one of the major concerns. So it would be a softly approach, depending on how chronic you have been. But we've had people up to 10 years post-spinal cord injury who are a range of dependent and independent walkers get on the device. We haven't had any, no, we have had some quads, but mainly we've had paraplegics on the device, and we've had some lovely outcomes. And again, I think because of that very specific and programmable repetitive task practice, they're getting some really lovely carryover, and they can feel the difference when they get off the machine, and it's really encouraging them to maintain that for anywhere up to 72 hours, depending on the individual. So thank you guys. As I said before, please don't hesitate to email me again if you have any other questions. And if you'd like to book in for assessments, we are still doing them through this COVID period as safely as we possibly can, obviously. And we'd love to see you in the clinic using the device. It's outstanding. All right, enjoy your day. Thank you, everybody.